All right. Good afternoon, everyone. I want to take a moment and thank you for joining us for the pharmacy growth strategies beyond dispensing this afternoon. We have several wonderful panelists with us, so I'm excited for you to hear all of that they have to say. And this is presented by RxSAFE. RxSAFE is a sponsor of the NCPA Long-Term Care Division. So I want to thank you for their continued support. And if you're not a member of the NCPA Long-Term Care Division, feel free to reach out to us after the webinar today. I think that you would find a lot of benefit in joining. I am going to go ahead and pass it over to our host for today, Rana Hauser.
Thanks, Whitney, and thank you to RxSAFE for sponsoring today's panel, Pharmacy Growth Strategies Beyond Dispensing. We're glad you could join us. I'm Rana Hauser. I'm the Senior Vice President of Policy and Pharmacy Affairs for the National Community Pharmacists Association, working on behalf of community and long-term care pharmacies, advocating on your behalf each and every day. So happy to be joined today by these experts that can answer some tough questions, but we're going to do our best to talk about the state of the industry and how you can expand your revenue opportunities. We're glad you could join us. We know today's challenging environment is tough, and pharmacies must do more than dispense prescriptions to remain viable. Diversifying income streams is essential for survival and growth. Today, we're going to explore strategies for pharmacies to expand beyond traditional services. Discover how to adapt and thrive by exploring new avenues for growth that are crucial for long-term success. I'm happy to introduce our panelists. We have Tim Mitchell, owner of Mitchell's Pharmacy. We have Leanne Haley Brown, Vice President of Business Development at Pharma Complete. And we have Debbie Marcello, CEO of Happier at Home. I'm happy to be with my esteemed colleagues today. It's always a pleasure to work with you guys and learn from you. Please, the first time you speak up, each of our panelists, say a little bit about yourself. But we just wanted to kick it off right off the bat. We have a lot to talk about. And for the audience today, please use the question and answer box to pose any questions you may have, and we'll leave at least 10 minutes at the end to get to your questions. All right, we're going to kick it off with a really a tough one here, but we're going to go for it off the bat. What is the biggest challenge you think independent pharmacies are facing today? We have obviously several concerns in our industry, decreasing payment rates, staffing issues, problems with cash flow and probability, just to name a few, but don't want to prompt too many responses there from our panelists. So I'm going to start with Tim and then go to Leanne and then go to Debbie. If you could each just briefly introduce yourself and bite off that tough question to start us off. Thanks.
Sure. Yeah, absolutely. Yeah, my name's Tim Mitchell. I have 3 community pharmacies. One is a cost plus pharmacy, and then I have 2 traditional pharmacies. We also have a closed door long-term care pharmacy, which I'm actually in the back of. I'm in the office of that right now. And then we also have an infusion pharmacy that we do sterile and non-sterile compounding. We're located in Neosho, Missouri. I've been here since about 1997, owned the store since 2003. Hopefully that's a good enough introduction. So, the challenges, I say yes to all those things that you mentioned, as well as a whole list of other things, cash flow issues, the low reimbursements, the leftover DIR fees from 23, the burgers that we're having to deal with now, brand effective rates, generic effective rates. They're all just absolutely sucking the life out of us reimbursement wise. So, back, a few years ago, I thought I've got to figure out some other ways of being able to bring some revenue in, because we all know community pharmacies are very nimble. I like to use the word nimble in what we do. And so I started working on those things. But, I think those things are really, really the things that are strangling community pharmacies right now. So I didn't really add much to your list that you've already prompted us with, but I will tell you there's a bunch of things that we struggle each time payroll comes due. We struggle looking at a lot of different things, just trying to pay our drug bills and all those things right now because the cash flow is absolutely terrible. So anyhow, sorry, I don't mean to start off with such a negative comment, but that's just where we're at.
No, thanks, Tim. We're trying to get real here, and we wanted to talk about the biggest challenge you're facing right now. So it definitely sounds like cash flow, profitability, payroll rises to the top for you.
Absolutely.
All right. Thank you. Leanne, we're going to move to you next.
Hey, Leanne Haley Brown, VP of Business Development at Pharma Complete. I also wear a hat in the long-term care at home space for CPESN and work with the long-term care at home network as well. I really just need to echo what Tim has said. In my work with pharmacies in pretty much any state in the United States, the number one thing that they're struggling with is cash flow. Trying to balance, what we're going to pay this week, and really the ones that are nearing the finish line with last year's DIR fees are going to stop coming out. They're a little frightened right now because they just don't know if they're going to make it across the finish line. And a lot of them want to get into new revenue streams, but lack the resources at the moment to be able to meaningfully engage in those. So I would definitely echo what Tim said.
Thanks, Leanne. Debbie?
Okay, I am Debbie Marcello. I'm a registered nurse and founder and CEO of Happier at Home. Really, my background comes from starting Happier at Home about 17 years ago locally here in Rochester, New York. And at that time, my mother was going through challenges with brain cancer. And so for the 6 months that she lived after that, I was the consumer. My mother was the consumer of home care. And it was a terrible thing. It was something that we felt like we didn't have control of. And so before she passed, I said, this is something that needs to change. So looking at home care from the consumer's perspective, that's what I did. And that's why I created Happier at Home. And I, about 5 years ago, started franchising. So I teach people how to do this and how to run their Happier at Home business. I am currently the host of the Happier at Home PRN podcast with the Pharmacy Podcast Network. I'm a Fox News contributor locally in Rochester on TV each week talking about geriatric issues and caregiving issues. And with my background as vice president of a large continuum of care retirement community, I bring a lot of information that most pharmacies don't realize to them and help them to be able to look at things from a different perspective. So from my different perspective, and with most of our franchisees being pharmacy owners, I see and hear that it is the lack of cash flow and their profitability. So that's one of the things we really focus on. I see that there are referrals that are walking in their door so they could diversify. So lack of capturing those referrals. I think processes may be lacking, a lot of automation and processes. And the other thing is for the pharmacy owners to have enough time to institute their strategies.
Thanks, Debbie. That's really helpful. And I always appreciate Debbie's perspective as a nurse and as a colleague in this role we live in, trying to care for our patients. I think Debbie brings a really important perspective and really makes pharmacy owners and pharmacists think outside their comfort zone. So appreciate all your insights, Debbie, and thanks for everything you're going to provide us with today. So I think suffice it to say that profitability, cash flow concerns, it sounds like you're definitely the top challenge that independent pharmacies are facing today. And at NCPA, we're working very hard to address that challenge, working extremely hard to get pharmacy benefit manager reform across the finish line in Congress in Washington, D.C. this year. The thing we're working the hardest to do is move towards a payment model that is transparent and consistent and predictable. So we're working very hard to make it a national standard that all Medicaid managed care programs have to pay you, acquisition plus a state cost to dispense amount, which we know hovers anywhere from around $10 to $13+. We're also working very hard to get Medicare Part D reform across the finish line that would lead to reasonable and relevant payment terms, because we know today we cannot stay in business with the terms that the PBMs offer us in these take it or leave it Medicare Part D contracts. So working very hard. Stay tuned. In the upcoming weeks, there'll be a big campaign that we're going to announce at NCPA, really trying to get consumers to also listen to this important message and care about their own healthcare and where they can access it, and working really hard to get consumers to weigh in with their elected officials and get this done this year. So more to come. Let's turn to our next question now. We just talked about why diversifying revenue streams is so important. It's essential for maintaining profitability. What are some of the most promising new revenue streams for pharmacies? I'm not going to name them all off here, but some that come to the top are clinical services, specialty pharmaceuticals, compounding, DME, long-term care. Let's just talk about what you guys see as some of the most promising new revenue streams or current, revenue streams that can be expanded upon for independent pharmacies. Tim, I'll start with you.
Okay. Yeah, sure. Well, I'm a firm believer in the saying of, you want something to change, but you don't change anything, or, you keep doing the same thing over and over again, expecting things to change. We've got to change things. And I made that decision. It was actually during COVID, that I knew something had to change, because I saw we were experiencing high DIR fees. We were having all kinds of issues that were just absolutely sucking us dry. And I will tell you that we installed a rapid pack machine. We brought in a new pharmacy system, and started doing medication synchronization, started doing the special packaging and so forth, and honestly started working on the long-term care at home part of the business and growing that. And we started off with just a few patients, just trying to figure out how we could do it. When we got the machine going, we've got over 1,000 patients now, and I think we have about 1,200 is what they told us the other day. And that's, some of them are in long-term care, some of them are medical at home or long-term care at home. But that's really been one of the biggest things for me. We do have our specialty and compounding pharmacy that's a separate license than what we have here. I just got a message that said we have 1,500 patients now. So.
Oh, baby.
So we're growing. And I have to attribute that to our team. Lacey Epperson is our pharmacist that's a clinical leader. I think she's on the call as a reason. She's the one that texted me, and she heads up a team of, I think we have 8 community health workers on staff, as well as, our other pharmacy technicians that are working on MedSync, but they're constantly looking for social determinants of health. They're looking for other opportunities. In Missouri, we're pretty fortunate that the state of Missouri gives us, or the Missouri Medicaid gives us ability to provide some services independent of a physician prescribing some things. And so it's really nice to be able to identify those through our Direct Care Pro and being able to build those accordingly. That being said, anything non-directly related to dispensing is what we're focusing on, because the same thing, the status quo has not been, a real positive outcome for everybody. So we realize that we've got to do some different things. I've been talking to Debbie about her franchise for, I don't know how long, Debbie, probably 3, 4, 5 years.
I was going to say like 2 years, 2.5. Yeah.
She
Time
told me,
to pull the trigger, Tim.
Yeah, she's like, I know someday you're going to be a happier home store. I'm not there yet, but we just opened up and just hired our own nurse practitioner. We have our own clinic through Big Tree Medical, through CPSN and so forth. So a lot of things going on. But, I think just the non-dispensing revenue part of what we've been focused on has been our lifesaver. The long-term care at home has been what saved our pharmacy over the last year. So.
Thanks, Tim. Thanks for that perspective. Leanne, just the best advice you can give for those non-dispensing related revenue streams.
So a little bit about dispensing / non-dispensing revenue stream. I want to piggyback on what Tim said regarding the long-term care at home. I think you need to have your head in the sand if you didn't realize how much I'm involved in trying to bring long-term care at home with the long-term care division, with CPESN to pharmacies, because here is where I think there is an opportunity based on having limited resources to get into something more profitable, because, you know, everybody would love to have a rapid pack, and it's a great machine. If do you have one already, you should be building out your long-term care at home. But if you can't, you could be doing it with blister cards or whatever. And this is a place where I know there are conversations going on where non-dispensing revenue is going to start taking place in January. These patients who are long-term care at home, payers are very interested in moving the needle clinically, using our pharmacist brains and our hearts that we have always had, and wanting to pay us for complete medication reviews, helping to gatekeep the health of the patient, decreasing hospitalizations. So I look at long-term care at home as more than just a dispensing process, but it's a patient-centric care process, along with, not gonna lie, Debbie's Happier at Home. If you're a franchisee, Tim, that's your captive long-term care at home audience. So in addition to that, though, you know, that might not be a passion of yours, but I'm also seeing a lot of collaboration going on in a lot of states with RTM and RPM, having meaningful conversations with a physician. Pharmacists cannot directly bill for RTM or RPM. Let me throw that straight out there. But that doesn't mean that you can't generate a good deal of revenue and improve patient outcomes for local physicians in your areas. And I think this is especially true in those rural places where the pharmacy might be the highest level of care that they might be able to get to within 45 minutes. So those are the two things right now where I'm being extremely supportive, and a lot of pharmacies are coming to say, okay, what does RTM, RPM really look like? It's not as hard as is it. And if it's something you want to be passionate about, seek someone out that's done it. I'm happy to introduce anybody to anybody. And so I think those are the two places right now where I feel with a little time investment and not a huge monetary investment, you can start generating revenue for your pharmacy pretty much very quickly.
Great. And Leanne, just to clarify that, you're talking about remote therapeutic monitoring and remote patient monitoring.
Yes, I'm sorry. We're acronymed to death here in the universe. Yes, ma'am.
Just to make sure our audience understands. Okay, thanks, Leanne. Yes, we all know that diversifying your revenue opportunities includes both dispensing and non-dispensing related services. So thank you for those thoughts, Leanne. And Debbie, you're up.
So I love what Tim's doing because he is diversifying, he's layering, he's putting up those different pillars to support his community. And I think that that's one of the biggest thing I see in pharmacy owners as pharmacists. You're not taking advantage of your education and your position in your community, not only for yourself, but for your community. They need you. They need the quality that you bring. They need to know that for someone who's it's center, like that hub and spoke, as I think Leanne was saying, that you're able to bring all these different things together, all these different types of services. So, you know, I'm thinking about Tim with 1,500 patients with Rapid Pack through RxSAFE. That's right there. He has a whole business of happier at home clients right there. You know, they are home, they're needing to stay home. And so what I would say is one of the ways to diversify your revenue is the home care piece of it. So it does not need to be heavy duty skilled nursing. That's not what we do. Happier at home business owners may have caregivers that once those compliance packaging, the compliance packaging is in their home, they may not remember to take the medications. What happens then? It's broken there. So once those medications are in the home, having a way to remind them. So I would say having caregivers to remind them, or even a medication dispensing system in their home, which you could monitor and that medication management. So looking at the patient holistically. The other aspect of home care, a little bit different than the caregivers that you have working within the pharmacy or the community health workers, sorry, I would say is the care advocacy and care management. So here you're helping the entire system and your community by being able to bring everything around and have it work together, sync together. So the senior population is growing. 10,000 people every single day are turning 65. And so many of those are either walking into your pharmacy or their family members walking into your pharmacy, and they really need you. So this is something that really would help your community too.
Great. Thanks, Debbie.
Yes.
Tim, can you expand? I know you mentioned the 1,500 patients. Can you expand and share an example of how, you've seen that aspect of your, diversifying your revenue streams, how you've seen that successfully implemented? Just walk us through a few steps from beginning to the point that you are at now with the 1,500 patients.
It's kind of a long story, but I'll try to make it as brief as possible. And by the way, actually, Lacey just messaged me, and now she just did another report, and she said it's 1,978.
Huh.
So we're almost at 2,000.
Things are getting better.
We're going to have
That's
to
great.
purchase another machine just to keep up. But I will tell you, we started off just very simple, working on, just trying to figure out a way to keep people compliant, adherent on their medications, using the cards like what Leanne had mentioned. We do have our closed door long-term care, which we take care of group homes and various things, facilities around the area. That being said, those individuals in the homes needed something as well. So we purchased some cards and started working on those. We realized really quick with the labor that was involved and what was going on, we were going to have to try to figure out a way to automate. And I needed to automate fairly affordably because I saw this, terrible situation coming down the road where cash flow really was bad. And so we took the leap and moved forward with that. That being said, hopefully I'm following what you wanted me to talk about here, Rana, but
Sure.
I wanted to create an adherence area in our pharmacy. So in the backside of our pharmacy, we had a warehouse that we had medical equipment stored in, and our records, and we have an upstairs. So I'm like, all right, all the medical equipment's going out, all the records are going upstairs, and we're going to make this an adherence area. We had a pharmacy that was in a town next to us that had closed. Unfortunately, chain ended up buying them. So I bought all of their fixtures, brought it into our warehouse, and set it up as our adherence area. Bought a few more computers, and just started training our staff on a different way of thinking. We're not going to work reactively. We're going to work proactively. We're going to create a situation. This was as soon as the pandemic hit. So we're going to create a different kind of thinking in pharmacy. Now, I'm not saying everybody was on board. They were like, what are you doing? Why are you changing all this stuff? I've worked here for 10 years. And some staff members said, I don't think I can do this. I'm going to have to, go find a job somewhere else. And, that being said, we do it. And we also had to educate physicians. We had to educate our patients. But, and some people are like, I just don't understand why you feel like you have to line all my medicines up. And I said, I'm trying to make it easier for you. And now when we don't make those calls, they're calling going, how come my person hasn't called me yet? And I'm like, well, she's on vacation. We've got somebody else that's going to make that call, in the next day or two or whatever. But they've developed that relationship. It's been very, very eye-opening. And I have family members that come in that are just so grateful for the fact that we offer these types of services. And we don't give them away. We actually charge for these services. And it creates some value. I mean, when you give something away, people, I feel like, expect it. And when you actually charge for it, they're like, okay, Some may say, well, that's not for me. I don't want to pay the extra fee for it. But most people feel like what we offer, and we call it a medication management fee. And that's basically what it is on a monthly basis. That being said, we have family members that come in to say, you've saved my mom from having to go into a long-term care facility. I can actually take care of her at home here, or they have another friend or family member that's helping them with it. And the medicine is one thing we don't know anything about, and we don't have to really worry about all those things. And if there's changes, they know they can just come to us and we can work on it. But that being said, it's created a much more proactive working atmosphere for us here in the pharmacy, as well as the patients. I mean, they expect those calls a week or so in advance before they're even out of medicine. And I've got people that are moving their prescriptions over from other pharmacies just because they've heard about our program, or want to be able to be involved with our MedSync program or whatever the case may be. So it's been a real blessing for our community. It's been a blessing for our business. The other thing that I had mentioned is my inventory was able to be dropped dramatically because I'm working proactively. I order things in and it goes out within 24 to 48 hours after me getting them in. The girls know this is when we need to order it. They'll put it in the order queue or put it in the basket for me to punch it in and order it that day. We get it the next morning. They're packing it as soon as they get it in. They're packing them and they're calling the patient. And so my inventory turns are so much greater, and I can keep my inventory much lower. But I had 3 stores participating in this program. We reduced our inventory over $150,000 just by implementing this program. So that's huge for cash flow.
Yeah.
Huge. So.
No, Tim, thank you. That's very helpful information. I know we'll probably get some questions and answers that we can, talk through at the end of our discussion here, but thank you. We'll give Tim a little break. I want to switch over to Debbie and Leanne, talk about some emerging trends. Debbie has talked about home care, definitely as something that's currently happening and really could be greatly expanded and have a lot more participation by pharmacy owners. Debbie, talk a little bit more about how pharmacies can prepare to capitalize on home care for patients, and then maybe walk us through a success story that you've seen and you've been involved with a pharmacy owner.
Actually, the way I started thinking about really focusing on pharmacy owners was because of one of my first franchisees. He owns a few pharmacies right in the middle of a city, which normally don't have higher income. But with his relationships that he has with physicians, different long-term care facilities, he was able to capitalize on those relationships to be able to provide home care, even in those independent living, especially in the independent living facilities. So being able to offer that, he is really focusing more so on Happier at Home. Another one of our franchisees said that this is her exit plan. A term of a franchise, you're building equity into your business. And after 10 years, you could continue on, or if you want to sell it, then that's it. You could have that capital. But it is a positive cash flow business. But with your pharmacy, you could also, with home care, provide different programs from your pharmacy to your home care patients. Point of care testing, things like immunizations. So you're developing these patients through Happier at Home, or if you're providing your compliance packaging at home, you have all these patients that you could offer more services to them to help them remain in their home and independent. I see a lot now of families moving away from their parents. So they really need that care advocacy and the case management and the medication management as well. So working together, even with that medication dispensing machine that we use, it has an online portal. You're able to sign on to that portal and see what their compliance has been. It gives audio reminders for them to take it. So this is a good option for those that that may have some dementia, or they still can follow some instructions like press the screen, then the meds are dispensed. But those people who might be really forgetful too. One thing that, just kind of coming at it from a different angle also, I think one of the emerging trends that we're right in the middle of is the marketing. We do a lot of social media marketing. I know one of our franchisees, Thomas in North Carolina, McDowell, he does TikTok, and he's a rock star. I mean, and that brings so much attention to your pharmacy, and especially to unique things that you might be doing. The marketing with social media, content development, email marketing campaigns, you have databases. And why not use those databases to stay in front of your patients and let them know the new things that you're doing and that are available to them?
Great. Thanks, Debbie. Yeah, lots to learn from you and those pharmacies who are franchises and about their successful stories. So thank you for adding some more flavor there. Leanne, we're going to switch to you. I know you talked about remote patient monitoring as an emerging trend. Just let's talk about that for a minute here. How can pharmacies prepare to capitalize on that?
So I think it's going to be very important in the future. And I know that, and Ron, I'm sure you can comment on this as well. Only 19% of Medicare patients who are eligible for remote patient monitoring are receiving this reimbursable service. And with the gobbling up of physicians' practices that are going into these large hospital systems, these patients are going to become less likely to get this service. So if there's an opportunity in your area to be able to provide this level of care to patients, even if they're not long-term care at home patients, because what the CMS data is bearing out is that patients who participate in remote patient monitoring programs are twice as less likely of being readmitted to the hospital. So in value-based care, let me set the stage for a second. So the world is moving to value-based care. I know as pharmacists, I mean, I've dispensed prescriptions now for 40 years. It's a transactional thing. It's a product, I get paid, and boom, it's gone. That's not the world of value-based care. The world of value-based care, it matters to the patient how they're cared for. It matters to the payer about the outcomes. It matters how we keep the bell curve, the patients in the middle who could move into needing higher levels of dollars spent on them. The purpose of remote patient monitoring is to keep those patients healthy for as long as possible with targeted interventions. And this, for me, frankly, this should be the realm of the pharmacist. I know there's will at CMS for this to be in the lane of a pharmacist. And I don't want to see another group of providers move in here and say, okay, well, the pharmacists aren't doing it, so let's do it for them. So I really think this is something that every pharmacy should be looking at. If you do long-term care at home, those patients are already baked in for you for remote patient monitoring. And then I did want to also mention point of care testing again. So if you also follow industry trends, and I know Debbie and Tim do as well, most patients at this point, because they got a lot of their COVID testing in a pharmacy, they loved being able to get tested in a pharmacy. And there are so many states now. The QAM this morning just denoted a couple of more states where pharmacists can now do and bill for point of care testing. This should be something that pharmacies are getting prepared to add to their normal line of business, just like immunizations now. And then the last thing, if they're not already, if somebody is not thinking about doing in-home immunizations for patients, they really should be, because Medicare Part B this year has instituted an at-home fee for the flu and the pneumonia in addition to the COVID. So basically, you get a $68 fee for going into a patient home and giving them an immunization as a Part B patient. We're still working on the Advantage plans. I'm not going to say it's a panacea, But again, all three of us and you, Rhonda, we're all talking about how can we step up in our communities and care for our patients. And these are just a couple of places where you can do that and improve the revenue for your pharmacy.
Yeah, absolutely. Well said, Leanne. We need to keep patients happy and healthy in their home. I mean, that is a job that we were well equipped to do, being that point of light in our communities as a local healthcare provider. We need to help patients age gracefully in their homes. And, that was the whole impetus behind long-term care pharmacy at home, is to really advocate for this level of service. It's a higher level of service provided by a pharmacy that's capable and willing and able to provide long-term care facility services to patients residing in their home who otherwise would need to be in a facility. We really do need to keep patients at home that wish to age, gracefully in their home
And
setting.
we're going to need to step up because, as Debbie said, 10,000 people a day turn 65.
Yeah.
Well, the number of assisted living beds is shrinking, not growing in this country. So
Yeah.
we're gonna hit a mass event where your mom might need to go into assisted living, but she's going to have to go 4 states away.
Right.
We're going to have to create this model, and it's going to have to be solidified because there's going to come a time when the beds aren't there.
Right. Absolutely. And NCPA is working really hard. We've helped create the Alliance for LTC at Home,
Yep.
which is a great resource for what these services look like. What services does a pharmacy need to provide to offer long-term care at home? And then who are your patients that would qualify for these services? So let's transition and talk just for a few minutes, Leanne. If you're a pharmacy out there that's considering expanding into long-term care at home, what are some of the industry trends or things occurring that you need to be aware of?
I think the number one thing that people need to be aware of if they want to get into this space and is that they need to go someplace to get information where they can do this correctly. We're at a place now where a lot of people have raised their hands and say, hey, I can do this. This is easy. But there are a lot of compliance requirements in place. You need to make sure that you are fully compliant with what CMS says you need to have available to be able to bill as a long-term care pharmacy. You need to understand what the place of service code versus a level of service code, and that you're not taking bad advice from your next door neighbor and billing a different place of service that's not appropriate. So going to places like the NCPA Long-Term Care Division, going to places like the CPESN Long-Term Care SPN, to make sure that you are setting yourself up for success. Because over the last few years, there's been a lot of confusion out there, but there are some great places now where you can go. I mean, Long-Term Care Division, NCPA, is an extremely reasonable membership fee. And there's a lot of great information behind that paywall. But that would be my number one thing, is make sure you are going to good sources to be able to get the information you need to be successful in this space, so that you're doing it right from the beginning. Because, Tim did that, right? I mean, he does his research. He's done everything the right way. But there are other voices out there that may not be, saying things the right way. So I think that for me is the number one thing. Is I want to help any pharmacy that wants to get into long-term care at home. The Long-Term Care Division wants to, you want to, Becky Sneed wants to, come to us so that we can make sure that you're getting set up correctly so that you can be successful going forward to be able to care for your patients.
Absolutely. Great advice, Leanne. As Leanne mentioned, there's a lot of things that go into this. We want to make sure these services are provided correctly. One of our ultimate goals at NCPA is to get CMS to not only recognize LTC at home, which they do, but the next step would be to require the Part D plans and the PBMs to pay pharmacies that are providing this service at a higher rate, akin to a more of a skilled setting, akin to patients residing in a skilled setting. So a lot of hard work being done, and just have to make sure it's being done right, and pharmacies understand what these services are, who the patients that qualify are, and how to document, make sure there's attestations on file that these patients actually meet the criteria to be able to receive this level of care. So thank you for that look and a little deeper dive into some emerging trends. Let's go back to Tim. And Tim, you've touched on this a little bit, but if you want to go into it a little further, we'd appreciate your expertise here. What revenue streams does your pharmacy currently offer that are cash-based and not DIR fee dependent? Because as we all know, the DIR fees that we used to know have quote unquote gone away as far as their retroactive nature, but we're at that washout period, right? Where we're still having to pay 23 fees. And then moving forward, plans and PBMs can still assess, at the claim level a fee. So, these fees and these price concessions, unfortunately, are not going away. Tim, what are you doing that's cash-based and can help mitigate these ridiculous PBM fees?
Sure. Well, yeah, just to be up front, I don't see DIR fees really going away. They just change names.
Right.
And of course you see it at the point of sale. So, back last year, actually about this time, we opened up a cost plus pharmacy. It's gaining some traction slowly. Not really where I want it to be just yet, but I haven't really pushed it as hard because I've been working to try to get another part of this business going, which is the Big Tree Medical Clinic, cash based. It's direct primary care. If you want to learn more about that, that's through CPSN, or you can contact me and I'll be glad to tell you more about it. But my goal is to utilize the Big Tree Clinic and be able to work collaboratively with our cost plus pharmacy to be able to do that. We've also partnered with a local direct primary care physician who's a friend of mine that he has about 850 patients, I think, last I checked, and all of their members for his direct primary care are members also of our cost plus pharmacy. So our cost plus pharmacy does a membership model and a non-membership model. There's never a PBM that's going to get between me and my patients in this model. I have never lost any money on any prescription that I've sent through our cost plus. So if you want to learn more about that, please feel free to let me know and I can tell you more about that as well. And, Kyle McCormick through Blueberry Pharmacy, I think everybody knows Kyle. He does a great job up there. He started, when the pandemic hit, and I started at the end of the pandemic. But it's something I've always thought about and felt like it was something that we could move forward with. That being said, there's a lot of things to think about, and I could get into the details on that at another time. But that's our biggest projects right now. We are doing some other types of projects with CPSN and some other things that Lacey's been working on here in our pharmacy. I think for the most part, the biggest thing is using our community health workers in our stores. Again, we don't bill insurances for our community health workers' work. A lot of times it's our pharmacy technicians that are trained as community health workers. I think we have 8 on staff now, which is pretty amazing for just a small, community pharmacy. But that being said, we're providing a lot of extra services that we're able to, in Missouri, it's a little bit different because we're able to have access to some funds and so forth. But I think there's a lot of positive things that are non-PBM related that are coming down the road. They're just not quite here yet, or we haven't got them to fruition because we've been working on so many other things. So
great. Thanks, Tim. All right, I have one more question. I'm going to ask each of you a different question, and then we're going to wrap it up and get to some Q&A. I think there's some really good questions that have been coming through. So, Debbie, I'm going to start with you. How can pharmacies leverage partnerships with healthcare providers and other community services to enhance their service offerings?
So the healthcare arena, the professionals in our system need this service. They depend on safe discharge home. They depend on home care to be able to really keep their patients independent and in their homes and to follow the medical regimen that they've established. So in this way, you would be partnering with hospitals, discharge planners, transitional care units, the other home care companies as well. being able to help maintain them in their home. That's one of the main reasons that you're able to leverage your relationships with your connections already with the healthcare system to use this cash-based source of revenue. You know, what I think people don't understand sometimes is that home care by large is not paid by insurance. It's an episodic payment when they're discharged from the hospital. Perhaps they may have a few visits just to help them have more of a safe discharge home. But we're talking about, you know, half-hour visits by a CNA to take your blood pressure, make sure you're safe in the bath, that type of thing. So with our model being cash-based, it really provides the services they need, provides a great 35% profit margin for you guys. And one of the things I really want to point out is that what I'm talking about doing and adding home care as a vertical to your business is what the big box companies are doing already. So they see it, they know that more home care is needed and people really want to stay in their home. So CVS has partnered and has home care services. They have a physician's house calls. So knowing that these, just like Leanne, or maybe it was Tim, saying that physicians' practices are being bought up, this is what's happening with the healthcare arena in the home. So you need a piece of that. You need to be able to claim your patients and make sure you're helping to take care of them instead of having one of the big box companies then kind of creeping in on your territory and taking care of them.
Now, that's a great point, Debbie. Thank you so much for that. And I encourage everyone to reach out to Debbie, learn more about Happier at Home and opportunities there. Very, very important. I'm going to switch to you, Tim, for your last question. How can technology facilitate the adoption of new services and revenue streams? Talk a little bit more about your adherence packaging and all you're doing with LTC at Home.
Well, I will say the adherence packaging, and I've said this to the Rapid Pack guys. I've said this to other pharmacists. I said it just a while ago. I do feel like our ability to provide long-term care at home services have saved our pharmacy, and using the Rapid Pack machine enabled us to do that very efficiently. And to be honest with you, has enabled us to grow that part of our business to kind of a business in itself, really. The other things that Leanne had mentioned with remote patient or remote physiological monitoring and the RTM are things that we're looking to try to add. We have not done that yet, but we do feel like there's going to be new revenue streams going with that as well. And then, of course, I think it's important that we continue to just be open-minded and be nimble to be able to add more services as they, come up. And it, other pharmacy owners that are much smarter than me are coming up with new and innovative ideas that just kind of blow me away as far as realizing the revenue potential. But I can tell you long-term care at home and some of these remote patient monitoring and remote therapeutic monitoring are things that we are currently looking at and being able to move forward with. So, and then of course the cost plus model, not non-PBM related revenue, and what Debbie's talking about with her Happier at Home are the things that we want to try to continue moving toward.
Great. Thanks, Tim. And we'll wrap it up, Leanne. Last question for you. What KPIs, key performance indicators, should pharmacies be looking at to assess the health of their pharmacy?
Now, how did I know that I was going to get a KPI question?
I thought you would be perfect for that.
So I'm okay. So I'll talk a little bit about KPIs, but one of the things I want to remind pharmacy owners right now, because I talk to a lot of pharmacy owners every week, and the number one thing everybody is focused on is each prescription that they have filled during the day where they lost money. And I 100% understand, as a dispensing pharmacist myself, that it's easy to get very centrally focused on the scripts that you're losing money on day to day. And I'm not saying you shouldn't look at those. but I'm afraid that some people have gotten so much tunnel vision over the last 5 months that they're forgetting to monitor things like their inventory. Tim mentioned this earlier, that with his model, he was able to reduce inventory over $100,000. A bottle on the shelf that you're not dispensing in the next 24 hours is money that's not sitting in your bank account. So that is huge for cash flow. So if you could spend just 10 minutes a day running through your shelves, and it's worth the effort to send those things back, or re-educate your team, say, you know what, we don't need this many, and print yourself a dispensing report. So the inventory KPI right now for me is crucial, that people are spending time for that. The other KPI is payroll, that I really think people should focus on. Look at your team. I mean, I bet you if I said to Tim right now, do you have anybody on your team that's not producing an ROI or a return on investment? How are they supporting those revenue generating opportunities in your store? If somebody is in a role that's not contributing to generating revenue, I'm not telling you to get rid of them. I'm saying find them a better seat on the bus. Right? Yeah. Well, if it's that one, Tim, yeah, chuck them to the road. But this person might not be in the right role either. So it's important that maybe every 6 months you take a look at everyone on your team. Are they their best selves in the roles that they're in? And are they bringing value to patients? And are they bringing revenue new to your pharmacy? Because the reality is, we're not in business to be a charity. We're in business to make money, and there's no shame in that. And then the other thing that I wanted to mention is, try to not hyper focus on the prescription that you're losing money on all day, but look at that overall gross margin per prescription, and you should be monitoring trends. Is it trending up? Is it trending down? Is there a particular insurance that's trending up or trending down? Because those contracts at this point are fairly stable, and you should be monitoring changes and reaching out to your PSAO if you're noting something odd, or reaching out to your long-term care PSAO if you're noticing something odd. Because pharmacies that were doing that were the ones that discovered that ESI earlier this year had loaded the wrong long-term care contract. So not hyper focusing on the loss of a prescription as you're filling it, but taking a bigger picture of your business and doing it frequently. And then the last thing I would say is, make sure that you have a person doing your finances, your bookkeeping, a CPA that understands the world of pharmacy. I can't stress this enough. You're supposed to hire somebody that's smarter than you. So my CPA needs to know what I know and just be a CPA. I don't have time to. So please, if you've got somebody that you're frustrated with that's not getting you good reporting for pharmacy, go find one. There's a lot of good ones out there. So off my soapbox now.
Thanks, Leanne. No, we appreciate your soapbox. Okay, we're going to get to some questions here. And Whitney Lynch from NCPA, back me up, but we are going to share this recording, correct?
Yes, we are. It will be posted on our website, and it'll probably take 2 days or so before we get it up, but just be looking for it on the long-term care portion of the NCPA website. And then it will also be under events, under webinars.
Thank you, Whitney.
Mhm.
Okay. I think I can take the first question with some help maybe from Leanne. There's a question about the LTC at home space, and are we seeing an increase in audits for pharmacies that are participating in LTC at home? Yes, and I think what we're seeing is the PBMs are making sure that pharmacies are coding correctly for patient residence code. So if a patient is truly residing in their home, we can't be coding 4, for example, or 9, for example. Those would be codes that are not, matched appropriately with where the patient resides. So I always try to make this, case when I'm on stage or on a webinar talking about LTC at home. You have to code correctly. You have to code that the patient is residing in their home. If not, the PBMs are going to monitor this. We have to do this right and correctly so we can expand these opportunities and really get CMS to see the value and how these services can save them overall, as a large government agency from increased long-term care and skilled costs. So Leanne, anything to add to that?
No, I would agree with that, Rana, and just making sure that, again, documentation. You've got your patient attestation form on file. You've got your delivery stuff all organized. You just they're just those elements that you need, similar to on the retail side that you need on the long-term care side. And if you have questions, reach out to people who are already doing it. If you're getting going. I will say the only really poor audits that I've seen were from larger billing groups that were billing a 04. A lot of the independent pharmacy audits that I've seen they're not recouping anything because people are, crossing their T's and dotting their I's. So
Great.
that's what I've seen.
Thanks, Leanne. A question for you, Debbie. Do you mind sharing your contact info in the chat, or just the general, the best way to contact you? We've had some people ask to contact you, Debbie. And then a question, Debbie, is a participant here is currently in talks with a company about providing care at home that is monitored by providers 24/7. Seems similar to what you are offering. How does it work in your model? Because I think this member is not seeing a lot of revenue opportunity in the other model.
Yeah, it sounds like maybe it's a referral type of model, possibly. But what our model is you actually are the business owner. You will be, and we coach you and support you with every step of the way. But with our model, you have a business support manager that will run this happier at home business for you. Sometimes it's someone from your pharmacy, sometimes you're hiring out from the community. But a 24-hour a day, 7-day a week case is like a dream case. You can make a lot of money on that. There's I think it's 168 hours every week that you would be billing, possibly at $30 an hour with a 35% profit margin. So that a 24/7 case, when we get a call like that, we drop everything and make sure that we're staffing that. So our business model is that you are the ones owning the business, you're providing the care for the patient, and we give you everything you need, the processes, the systems to be able to do that. And as far as my contact info, Rana, if I type it within that question here, will everyone see it, or I'm not really sure?
Just try that and we'll see. If not,
Okay.
you guys always contact NCPA and we'll help you out.
Sure. My email address is debbie@happieratHome.com. So that's DEBBIE and the @ happieratHome.com. But you could also go to our website at happieratHomefranchise.com. And there's so much information there, a lot of testimonials, FAQ that you could take a look at.
Great. Thanks, Debbie. Tim, your medication management therapy fee, your med sync fee. I know you talked about some fees you're charging. Can you just expand a little bit? Is it monthly? What does it include?
Yeah, we do it monthly, and it's typically billed directly to the patients. Now, there are some that they are able to not have to pay that directly. It could be our Medicaid patients, Missouri Medicaid patients, and the ones that actually qualify on long-term care at home don't actually have to pay that extra fee because of the way we have it set up in our policies. That being said, it's a general fee that we charge on a monthly basis. So
okay, that's helpful. And then, do you do monthly packaging or weekly? And if weekly, how do you handle mid-month changes?
yeah, I saw that. So I see another question there. It said something about, do we charge for MedSync? We actually do not charge for medication synchronization. That's part of the process, but the whole medication management fee part of that will include MedSync in addition to a phone call and check-ins. So that being said, if we do have some long-term care facilities that just want a week's worth at a time, it's a little more labor intensive, and we can do that, or we do the strip packaging a month at a time. Instead of just delivering the 7 days at a time, we could do 30 days at a time if the facility is okay with that. The other part of it, mid-month changes are a challenge, and I do have I think we have about 5 individuals that work in that area. And if it's something that, if it's close to the end of the month, or midway through the month, those changes, we will typically put the new medicine in a bottle. If it's something that has to be removed, we'll ask them to bring it back and we can remove it and repackage it for them. It is labor intensive though. And if there's someone that has a lot of changes, it's probably best to not put them in the packaging until you know for sure you're at a stable time, so that you're not having a lot of changes. And I do have a long-term care at home attestation. If anybody wants a copy of that, you can email me and I can send you a copy of that. My email is tim at mitchelldrug mitchelldrug.com, and I can send you more information if you have other questions as well. So
great, thanks, Tim. So I think we've answered most of our questions. I think one thing, Leanne, could you touch on before we have to wrap it up here is just generic kind of, how do you bill for remote monitoring?
Okay. So to reiterate what I said earlier, there's no place, unless you're in a value-based care contract through CPESN with a local payer, there's no way for a pharmacist to directly bill for remote patient monitoring or remote therapeutic monitoring currently. You do need to collaborate with a physician's office. That physician needs to have a relationship with the patient, and then you will do the work, the physician will do the billing, and you will have an opportunity to be paid for the work that you do from the physician. It's called incident to billing. We're not going to get into it today, but reach out to any of us and we can talk. Rana and I can talk to you and give you more explanation, because that's a little bit more into the weeds, but happy to have a conversation with anybody about it.
Well, thank you, Leanne, and thank you to all our panelists. Today, we've explored effective strategies for introducing new revenue streams into pharmacies, as well as challenges and opportunities that come with diversifying services. We hope you found the insights from our expert panelists valuable and inspiring. Should you have any further questions or need more info, please feel free to reach out to any of us directly. We are always happy to help you as you look to expand your service offerings and diversify your revenue opportunities. So thanks again to RxSAFE. Thanks to the NCPA Long-Term Care Division. Thanks to my colleague, Whitney, and thanks to each of you panelists for this great discussion. I hope everyone has a great week and a great summer. Thanks, everyone.
Thank you.
Bye.
Thank you.
Bye.